If you haven't done so already, please give Ryan Mackman, who's in the back of the room in the pink tie, your business card, because we're going to do an Amazon gift card raffle at the end of the presentation. And you got to be present to win. And I think chances are pretty good in this room. All right, so our presentation today is called Empowering Providers Using Data to Enable Continuous Performance and Quality Improvement. So, hot topic right now. I'm going to get started with introductions, and we have a great panel today, highly experienced individuals in value-based care. And I'm going to start all the way at the end with Maria Nicole. She's Salient's senior business consultant with over 12 years of healthcare experience in operations and strategy. And when she isn't leading our business partnership and development efforts through deep policy research, she's figure skating or sailing on the Chesapeake Bay. Next on our panel is Allison Casaccio. She is VP of Client Services and is a board-certified nurse in informatics. She has multiple EPIC certifications with experience using several popular EMRs. And when she isn't helping provider organizations optimize their quality metric reporting processes, you can find her honorably a part of the Nebraska Nurse Honor Guard or making homemade jams. Next, we have Jeff Yasili, the VP of Operations and Major Accounts. He has over 25 years of experience working in healthcare IT with IDX, GE, and Allscripts. He has a Lean Six Sigma black belt to assist with quality metric improvement techniques. And when Jeff isn't helping the quality teams be successful, he's building and flying racing drones for video content, which is super cool. And then lastly, you have myself. I'm going to act as today's moderator. If I look a little excited or if I got a lot of sleep last night, it's because I just left my 1-year-old at home for the first time, and I had her during the pandemic, so that was fun. I've been working with ACOs and MSOs across the country, and I act, as the principal business consultant at Salient, I act as a liaison between our clients and the developers of the solution. And that way, we basically align all of our products to match with policies and procedures that are constantly changing in this environment. So as you can see, we have a nice panel today, and if you have any questions, which we'll take at the end of the presentation, if you don't get to them, we can see you at our booth. We're in the main room, I think Liberty A, so you can come find us there. So let's move on to our agenda. Empowerment is absolutely key to change management. If you're trying to change and move from fee-for-service to value-based care, you need to properly empower your providers, give them the information they need so they can make the right decisions to move in that direction. So we're going to start off with the progression and current state of ACO data. We're looking at it almost from two sides of a coin. You have the true ACO data, your claims, your clinical data, but then you also have this whole component of quality metric submission that's following a little different of a timeline. So we're going to go through that. We're then going to move into what you actually need infrastructure-wise to manage your ACO. So there's a lot of data. What do you need to put it all together, and how do you even measure it? Then we're going to move into the empowerment part for your providers, some communication tips and tricks on how to give that information to them so that it meets them at the level that they need it at. And then lastly, we're going to cover the old buy or build question. It's going to come up time and time again, especially now with all the quality metric changes. So we want to give you enough feedback, tidbits to take back to your organization so that you can have a better discussion when this topic comes up. So let's begin. ACO data has been transforming since the birth in 2013, and we know that they're taking stakeholder feedback constantly. So there's been a progression. So I'm going to have Maria talk about the various data components and how you might want to use them and fit them into your solutions.
All right, thanks, Amy. So your data sources could be grouped into 4 different buckets, and that's claims, clinical data, HIE and ADT feeds, as well as other data sources. Your claims data is going to be either adjudicated or pre-adjudicated claims. Your pre-adjudicated claims are really helpful when you're doing quality measure reporting, and they're going to come in as 837 files. Your adjudicated claims are really helpful when you're doing performance management. In terms of clinical data, those are going to be from your EMRs, and it's going to be really difficult to really aggregate all of them, especially if you have multiple EMRs or even different versions of the same EMR. And those are typically used when you're looking at care management initiatives as well as your quality reporting initiatives. Your ADT and HIE feeds are really helpful when you are looking to implement acute or post-acute care initiatives, and you'll receive data coming in through your HIE and ADT feeds for initiatives like transitional care management, for example. And then you have other data sources. Those other data sources are typically used to fill in the gaps in your claims data and clinical data. And an example of that would be CMS Compare. So you're looking to, for example, create a preferred provider network. And as you do that, you'll fill in the gaps in your quality measure reporting, for example, SNFs or home health agencies, and then use your claims data in terms of utilization.
Nice. So there's clearly a lot of different data sources you're pulling together to create the big picture. Can you talk a little bit about a specific example where you were missing data, or you had an instance where you absolutely needed it and you had things kind of changed around to better suit your needs?
Yeah, absolutely. So as organizations engage in more and more value-based contracts, you're likely to receive data from multiple data sources. And, basically those data sources are not going to come in uniformly or even throughout the same time. Now, a specific example would be that as many payers don't provide that data, and an example would be when a provider doesn't provide the names of your out-of-network providers. So all you're going to get is a number and an out-of-network designation. So as you look at your network leakage, for example, you'll identify the facilities, and you have two options in that instance. One is looking at creating your own crosswalk or going back to that payer and actually asking them to fill in your out-of-network designations.
Nice, and that could be difficult when you have data gaps and you're trying to fill them in, but having the bigger picture using all of your data can help fill those gaps in nicely. So next I'm going to hand this off. We're going to talk about the progression of quality metric reporting and what we're looking at today with the proposed rules that we have.
Thanks, Amy. Yeah, this is CMS is definitely playing a very long game here. It's got a very, very big ship to turn. So it's working from that movement of our fee-for-service into value-based care, and we've been working on this for a while. So we've seen a steady evolution over the years. Without spending too much time on reviewing the history, CMS started with pay for reporting. They transitioned to pay for performance. Programs also have a progression inside them. So you see increasing requirements, and you see incremental changes in terms of incentives and penalties. So they start with carrots, more carrots, another carrot, and then they start rolling out the sticks, and getting bigger sticks is really trying to pick up that pace towards value-based care. If we jump up to the recent past, 2021 final rule postponed the implementation of MIPS value pathways, and as I'm sure everyone in this room knows, it eliminated the web interface reporting. So that's a really, really big change. The web interface is being replaced by the APM performance pathways, and with the pandemic raging, it really wasn't a lot of changes other than the APP for 2021. So we've recovered a little bit anyway, and the 2022 proposed rule is out. CMS actually just stopped taking feedback on that rule it was just 2 weeks ago now. So we'll be really interested to see what happens there. Probably the biggest thing, particularly interesting for this group, is it actually postpones the rollout of the APP for about another year and a half. It changes the rollout a little bit there. We're seeing mature MIPS at this point where the reporting categories for MIPS have reached their final weights. We're seeing MVPs will actually be happening in 2022. We'll see subgroup reporting, which is really, really good news for multi-specialty groups. There's a move towards digital quality measures. So that is planned for 2025. Again, typically ambitious. CMS will see whether vendors and organizations can actually meet that timeline.
Keep your eye on that one.
Yeah, that one's going to be interesting. There's a lot there to discuss really for another time. Streamlining and alignment are definitely a big theme here in that evolution. We're seeing, I think it's worth saying really that the move to APP is exactly along those lines as far as trying to streamline things. The APP really aligns with the MIPS value pathways. Just a couple of key points around the MIPS value pathways. Limited measures that try to be more meaningful and that are reducing the burden on clinicians. We'll see exactly how that works. Measuring measures that use comparative data. That's one of the challenges with all of the programs and all the different measures is it's very hard to get a global view and compare all providers against each other on all groups. Measures that include patient voice. Consumerism is definitely a big issue and is actually a key point of feedback of really assessing how patients are feeling about their care. And then last, lowering barriers to the APMs and creating participation in those APMs is really where CMS has been focusing. The QPP is divided between APMs and MIPS, and they are definitely putting a real focus on those APMs because that's how they're going to really drive value-based care. Those programs link cost and quality, and that's exactly what they need to do to make that happen.
Yep. And this group is going to be moving, if you aren't already an APM, to that direction anyway, because the Pathways to Success does that for you. So I'm going to ask a similar question that I asked Maria. Can you give me a specific example to where the data and some of the changes in the program have helped organizations for the better? What kind of alignment has changed? What has pushed us in a better direction?
Well, when we speak about quality data, I think the first time when we really think about seeing our quality data in our dashboards was through the incentive program, right? So we have all of these EMR quality measures that the clinicians are seeing for the first time. But one of the things that I like to remind people from an informatics perspective is that the EHR incentive program was not a quality program, right? It was a program designed to get technology going and get it embedded into our practices. So in many cases, especially early on, we weren't required to actually report any numbers through those, right? We could report zeros, totally fine. But if we think about that from the perspective of our clinicians, I'm seeing tons of diabetics every day. I'm documenting it the way the trainer says I'm supposed to be documenting it, but now I go to my dashboard and I get nothing in return. So we sort of, not of our own fault, established this sense of mistrust. And I think that those sorts of perspectives are really important. Look, we didn't know what we didn't know at the time. But now the data's matured, right? Jeff just talked about the programs have matured. And I think the next big step for all of us is to make sure that our communication with our clinicians also matures so that we're showing the clinicians information, not just data, but information that's, for them, it needs to be visually clear. It needs to be understandable at a glance. And it has to have a process behind it that continues to reduce burden so that they can do what they need to do, which is take care of patients, right? And I guess the biggest change that I see today is that the practices that we work with are now ready for these insights, right? We weren't ready for it back in the 2000s. We were all still getting used to what it meant to have technology embedded in our practices.
Beginning of the long game.
Beginning of the long game, yeah.
So we're compiling all this information. We have a lot of programmatic changes. You're going to need infrastructure to manage all this, put this in a central location. What exactly do you need in terms of data analysis?
So there's going to be 3 components that you need in place in order to manage all of those contracts. And that's performance analytics, quality measure and reporting, and care management. Now, all of those components need to be in a single place and, most importantly, in a single login. What you're going to need is the performance analytics to tell you what the areas of opportunity are, and then your care management system to actually implement some of those initiatives that you identified in your performance analytics. Your quality measure and reporting system will tell you whether you're closing gaps in care for all of those patients that you're actually responsible for.
And so once you have these systems set up, you're going to need to actually do some measurement. So what we've done at Salient is we've broken it down into 5 main domains. The first 2 being spend and utilization, because they have a cause and effect relationship. Then you have risk scoring as your 3rd, you have attribution as your 4th, and then quality as your 5th. So we've kind of broken them out, although they're all interrelated. So we're going to go down the line and talk about some of the key performance indicators you're going to look for across each of these domains, and maybe some uniqueness for ACOs in these components. So let's start with spend and utilization. Can you talk a little bit about what those KPIs are, why you might look for certain things for the ACO program?
Yeah, so as Amy just said, the nature of the finance and utilization domains is that they really have a cause and effect relationship. And it's really a component of the triple aim to decrease unnecessary expenditures. And this comparison could be either using the historical spend or through a benchmark, and that's determined by each of the payers. Now, to keep track of spend, the organization is going to need to understand exactly how they're performing over time to ensure that overarching goal has been met. Now, to achieve that goal, it's really important to decrease utilization over time. However, what you're going to see is an overall decrease in utilization can often lead to poor outcomes. So it's really important to identify what those most opportune areas are. Now, in value-based care, that's really defined by a decrease in either duplicative services or those that are clinically unnecessary, and an increase in preventive services that promote improved outcomes. Now, patients that receive services within the network are really likely to receive coordinated care and thereby decrease unnecessary utilization as well as those duplicative services.
We have a point on the slide that talks about percent change. Can you just allude to that a little bit more?
Yeah, absolutely. So what you want to do is continuous process improvement. And the percent change, either at the organization level, the provider, or at the practice level, really help to define whether your organization is decreasing that utilization over time and having the positive improvements that you're looking for. So you can compare either last year to this year or last quarter to this quarter.
Absolutely.
Goal setting.
Goal setting.
Right. So the next category is risk scoring, and it might not be front and center of all of your payer contracts, but it is a component, and it's really important to keep track of this because it will ultimately affect you, whether it's your benchmarking or just money you're getting for capitation payments, et cetera. So can you talk a little bit about this domain and what measurements you're looking for here?
Yeah, so for those of you that were here yesterday, the panel had spoken about risk coding, and CMS really uses that to assess the acuity of illness of your population and therefore predict the financial performance by means of the HCC, or the hierarchical condition category. And that uses the demographic information in conjunction with the diagnostic components to assess how healthy your population is. Now, the acuity of illness is really an indicator of how costly that population will be to determine the financial benchmarks. To compute the HCC, the weights are going to be assigned by diagnosis code within those claims. Now, specific chronic conditions will typically have a higher weight, so therefore it's really uncommon to see a patient's risk score decrease over time if they're really diagnosed appropriately. Now, this becomes a KPI that you want to ensure is monitored both at the organization, provider, and practice levels.
Yeah, if I could just jump in there, we're seeing a great example of this. CMS's Innovation Center, it's kind of a laboratory where they build some of these programs and start testing them out. They created a new APM that's actually just gone live this year called Primary Care First. And it's really fundamental to the quality process of really trying to address issues as far upstream as possible. and the cost of managing patients who have multiple chronic conditions can best be done in that primary care setting. Unfortunately, historically, the cash incentives or the financial incentives haven't really been there, and this program really focuses on incenting the primary care organizations. And one of the big things that we saw during the application process is that there are scaled groups or risk factor groups. So depending on which group you're in, it determines the level of your payment, your APM payments, your per beneficiary per month payments. And there's a significant difference between Group 1, which is low risk, and Group 4, which is extremely high risk. They even have a seriously ill patient population, which has even higher incentives or prospective payments. And those are huge. So as we were going through this application process, we found, not surprisingly, that a lot of our customers really couldn't do a very good analysis on what their risk scores were. And as a result, when they were accepted to the program, most of them were very surprised that they were scored or put into a risk category lower than they expected. That reduces potentially the financial results of the program, but it really highlights the fact that this, as Maria said, is driven by data. It's driven by diagnosis. It's driven by coding, right? So most practices, at least small practices, don't invest in professional coders, and they historically undercode. So this program is a really great illustration of what the impact of that is. You're leaving a lot of money on the table, and you're assuming a lot of risk for patients that you don't have a good handle on.
Absolutely. Thanks, Jeff. So the next domain is attribution, which really flows through all the other domains, because if you don't have your population stable enough, you don't have that predictability element. It's too much variability that you're introducing when you're constantly adding and removing patients from your cohort. So let's talk a little bit about what you might want to look for or assess in your population.
Yeah, so continuity of care is yet another pillar of the triple aim. And in order to achieve appropriate spend, utilization, quality, risk scores, patients really need to engage with their primary care providers at a regular cadence, not during just annual wellness visits or sick visits, but really at both. A population is really best managed in a continuous fashion, and that means that you're seeing your patients regularly. CMS indicates that 70% of the Medicare population has 2 or more chronic conditions, and that means that they need to see their primary care provider on a quarterly basis. The KPI to ensure that primary care utilization is really key, and it's really important to look at the percent of visits on a quarterly basis, and that ensures that there's continuity of care and that the churn rate is optimized and decreased, and you're looking at the percent continuously attributed per quarter.
Absolutely. The care management programs are a great way of managing, proactively managing your attribution. I'm going to draw back on the primary care first program again because there's a very clear connection between your attributed beneficiaries and your prospective payments, and so driving that attribution has a very real and very quick impact on your finances. So we've been talking a lot about data and measurement, and this idea of it's really what do you do with this? What are you learning, and how are you improving your processes and focusing on what matters most, like attribution, for example. So Maria talked about the annual wellness visit, a really, really big driver of this, and most groups don't take full advantage of that. It's really kind of surprising. But one of the groups that we worked with, we actually started a program with them where we were doing the health risk assessments, actually making calls, scheduling appointments for these annual wellness visits, and doing the health risk assessments to prep those to actually shorten the amount of time that the providers actually have to spend with the patients. And just doing that in 9 months, we increased the group's attribution by 78%. And that was just in 9 months, just being a little bit proactive on it. For their APM payments on a month, for an annual basis, that resulted in almost $400,000 in additional payments. So it's really like understanding what your levers are and where you can really make an impact, and really focusing on the things that are most important.
Yep. And
My
you can
contribution.
tie financial metrics to it too, because you can see, just like you talked about, there is a difference between a new patient and a patient you're continuously managing. You're able to decrease that spend over time because you're properly managing them.
Absolutely.
So lastly, we're going to talk about quality. I have 3 bullets here because we kind of break it into 3 components. The first being that you're going to be doing the CAP surveys. Then you have this whole concept of delivering the care and making sure you're closing those care gaps throughout the year. And then you have the submission process. So it's kind of 3 individual components. So let's talk about some of those measures there.
So I think when it comes to quality performance, it probably goes without saying that being proactive is key. I mean, everybody in this room knows we want to be proactive about it, right? I think one of the big changes that you'll see as we move from web interface into the APP, though, is that sampling method that's used by web interface sort of fundamentally from an operational perspective separates the work we do to improve the care with this extra body of work that we do at the end of the year to gather our reporting together. And what's nice about the APP is that's going to bring that back together for you. So the measures that we're looking at and tracking all year long to try to get our quality of care high is going to give you the information that you need to decide where to spend your efforts, right? So we learn as we go, and it's the same patients that we do the submission on at the very end with just a few clicks. Right? So really what we're doing is we're managing this entire population. And if you can identify, say in June, that you have a measure that's lagging, now you've got time to really investigate it and try some different interventions. I like to present it really almost from a clinical perspective. Is it a documentation issue? Is it a workflow problem? It could be a communication issue where the providers literally don't know exactly what they're being measured on. But if we apply the wrong intervention, we're not going to get the results we want. So figuring out early what is the actual issue with my lagging indicator and then applying the right intervention, now you see fast improvement. And that takes time to do. You have the time now to work through all of that throughout the year. And like I said, at the end of the year, we do the submission in an electronic fashion with a few clicks and we're done.
So I was going to ask a few questions in the beginning, but the room was just starting to fill in, and now we have a pretty large group. So I'm curious how many of you in the audience are thinking of submitting through the APP this year as opposed to doing traditional web interface? Can you raise your hand if you're that risk taker in the group?
There's a couple.
Yeah, there's like
I'm
2 or
thinking
3.
about
That's all right.
I think that's great because you're being proactive. It's coming, right? So you got to prepare for it whether you're ready or not. So that's nice to see. All right, let's move into empowerment of providers, which is key to all of this. We talked about where we're at in our requirements programmatically. We talked about what kind of data you need and what kind of infrastructure you need. Now it's giving that information to the providers who can make those decisions on the ground. So how do you empower them? What kind of communication do you need to make those differences? We're first going to start with scorecards. They're absolutely paramount to changing behavior, and they have to be customized not just at the organizational level, but at your practice and provider level, so TIN and NPI as well. So let's talk about some of those components and what you've experienced using scorecards.
Yeah, so not only does your ACO contract mandate that you provide that insight to your providers and practices over time, but it's really a key pillar to continuous process improvement and thereby your success in value-based contracts. What's also really important to identify is not only do you need a scorecard that is customized to the TIN and NPI levels, but the ability to ask ad hoc questions and that ad hoc functionality of your performance management system. And I'll pass it to Allison to talk a little bit more about quality.
I love quality scorecards. That probably goes without saying based on my role. I feel like a lot of the data visualizations and things they need to be intuitive. We know it when we see it almost, but it's difficult to express to our vendors sometimes what is it that we actually need, right? Scorecards that get provided to clinicians have different goals than the scorecards that you need for your own work, right? So absolutely, they're necessary for running the ACO, and you've got to be able to see what's going on at the entity level, what's going on at each TIN, what's going on at each individual clinician, ideally be able to drill all the way down into each individual patient, right? However, when we're giving it to a clinician, and we have to, right, for the reasons you mentioned, but also, if they're not aware of how they're performing, then you can't expect any change, right? Once they have that visibility, and if it's displayed in a way that gives them fast insight at a glance, especially that insight that drills down to each individual patient, ideally the ones that they are seeing that day, the next thing we may need to do is provide them with a workflow. Because you can't just give them something that says, hey, here's where you seeded the data, but to really communicate, here's when to come and check the scorecard. How frequently do they need to look at it? Incorporate that quality check into their daily or weekly routines. And the main reason I say this is we know all our practitioners are living in these 15-minute increments, patient visit by patient visit, and they have all these different priorities that are competing for their attention. But we also know that our clinicians are the A+ students in the room, and they like being the A+ student. So if you give them a display, first of all, that they trust, and second of all, that they can take action on, that's going to make an incredible difference to their scores. That competitive nature that just exists in healthcare is going to really come out because they're going to compete to be the best, and that performance improvement is really what rolls up to the ACO entity performance level for you too.
That's interesting, Allison. I was just thinking about this from a quality perspective, and that we're talking about communication. What we're really trying to do is not meet a regulatory requirement, not produce a scorecard, not have a bunch of numbers, but to actually lead change. There's a great book, a seminal book called Leading Change by John Cotter, and GE actually condensed that into a process. I know, surprising. GE has a process for that. But that process is called change acceleration, or CAP. You can look that up, Google that. There's some great stuff. And Allison, one of the things you're talking about is this communication is really creating the shared vision for change, and that the whole organization is doing this because they all agree that it's the right thing to do to be successful.
Right.
So you have these scorecards, and Allison touched on this a little bit, but it's the fact that you need metrics that are understood and are fair to the provider. And I use the same example constantly because as a consultant, I've gone and spoken to providers, and if you give them the IP per 1,000, they will tell you, I do not practice in the hospital anymore, so how can I impact that? It is way better to show them their office access by means of how many visits they have on a quarterly basis, and their ER per 1,000, because we know that that is a correlation to IP per 1,000. So showing them those specific metrics that they can impact themselves in their office is sometimes a little bit more fair to them because they know that they can control that. So there's other examples here, but you should be looking for proxies and some other things. So let's talk about some of these understood and fair metrics.
So just like the scorecards need to have strong, actionable information. When I think about fairness to clinicians, I actually think about the measures that you're looking at. So the measures in the APP, this may be one of the first times today you guys are going to hear people talk really positively about CMS. I love the specification sheets, okay? And the reason for this is because it's actually helpful to drive, again, this communication. So each specification sheet for each measure has a clinical measure steward. And that's helpful because what those measures are really reflecting is best practice recommendations that were written, designed, and published by clinicians in the field of medicine related to that measure, right? So in addition to explaining what action needs to be taken by my clinician in order for patients to fall into that numerator, I can also point them towards the measure steward, which has contact information. I can give them the clinical recommendations associated with the patient population, links to peer-reviewed studies that the practice is based on. What this is giving me is the why. Clinicians have been taught to be critical thinkers. So when the software or EMR tells them they have to take a specific action, they're going to question if that's the right thing to do, and they should. We want them to continue to use their clinical minds, right? But in order to be a strong leader here, we've got to be able to answer that why, be able to speak to it, and show how this measure ties to their patient outcomes and ultimately to the aims of the ACO. And so clearly what we want is a real dialogue, right, between the administrative management of the programs and the day-to-day care of the patients. And I think that all starts with this. It starts with helping them understand the metric that's in front of us.
All right, so you have all this information. Now you need to communicate it with your provider. And we talk a lot about meeting the clinicians at the location, the place, mindset that they're at. So they might not be super tech savvy. They might still want a fax document. You know, you need to meet them at the level that they're at. So let's talk about what's needed to make that communication.
Yeah, so first and foremost, communication needs to be either physician to physician or with a physician champion. It's really effective when you have somebody that's their peer communicating that information to them rather than somebody like myself who's a non-clinical person that's never actually gone in and seen a patient. The other aspect of it is value-based care is a team-based effort, and that means not just the physician needs to be on board, but that the entire practice needs to be on board with that practice transformation effort. And last but not least, it's really important to deliver that information in the method that the provider really wants to see it in. Whether it's a login to yet another portal, which is not typically a favorite of theirs, or alternatively, a PDF. Of course, it needs to be in a secure email, not non-secure email. And then also, you could provide that in a paper format. So a lot of providers still really prefer paper. They're able to shut down their EMR. They're able to shut down that email. They're not distracted by that information that's coming in at them, from all over the place, and they really can sit down, say once a week, once a month, and look at their performance.
And it's a range, right? I mean, we all have both providers and administrators that are really slick and are really tech savvy, and maybe what they'll do is they understand the metrics. They're going to log in daily. They're going to go in. They're going to close their own gaps. Great. Then all we need to do for those folks is give them the knowledge, access, and autonomy to just get it done. And maybe then there's a lower level of that where we have a team that really just needs maybe a little bit of monthly project management assistance, some CAP assistance to really get that change accelerated. We can support that too. And of course, everybody has one or two staff members or sometimes even one or two practices with administrators and clinicians that are totally new to the program. And that's okay. Those tend to be actually some of my favorite people because everybody has to start from somewhere. And so if what we're doing is we're taking the specification sheets and printing them for you, and we put them in a binder, and you highlight the things that you need to remember, great, right? The key is we have to meet each of those groups where they are so that we can bring everybody up to the same level. Otherwise, you're just not likely to be successful. You're talking over their heads.
Right, bring up to the same level. You talked about workflows, you talked about communications and preferences, and certainly you want to respond to preferences so the people that need to consume the information can, will, and do consume that information. But also as part of the leadership, you really want to be able to start managing and adjusting those preferences. And again, using good communication tools, using the CAP process, you can actually influence that. And if everybody's talking about this, all of the other A+ students are talking about what's in the dashboard, and I don't like looking at the dashboard, I'm probably going to change my preference.
Yeah.
All right, so we're going to talk about why you might partner with a vendor, and the answer is you're on some sort of spectrum as an ACO. You might have all the resources you need in your organization. I think that's kind of the minority. And then ACOs typically fall along a spectrum of, we're independent practices with multiple EMRs, or we might all be on the same EMR but different instances. So that could be problematic for quality metric submission. So you're going to need to think about what you need to partner with, how you need to partner, and what are some of those questions or concepts that you need to think about when you're diving into a partnership with a business vendor.
Right. Yeah, I think particularly having many years in vendors and building these systems, one of the key things is whether you're building them or whether you're buying them, you really need to do an in-depth needs analysis for your organization. What are you trying to accomplish? What are the key things that are most important to you? And what I've seen over and over again, and this is kind of the devil accusing himself here, but that if you don't do that needs analysis, then you're going to be responsible responding to a sales pitch, and you're going to be told what functionality is important. And then you end up making an emotional decision based on how much you agree or like the salesperson instead of what you really, really need. So doing that work up front is hard work, but it will pay huge, huge dividends. You don't want to get into a situation where you're buying functionality and then inflicting it on your clinicians.
Right, right. There's just more efficient ways to achieve your goals than to take functionality that the vendor says exists and then force everyone into those workflows, right? It should be a relationship. When you're comparing vendors, right? One of the things that I think is really helpful, and maybe I'm saying this just as a clinical informaticist, if you have the opportunity to have a clinical informaticist early in that conversation before you even start the demo process, they help with the needs analysis. It's what we're trained to do. We're trained to understand the rip and replace process. Right? So what they'll do is they'll give you questions to ask in your vendor comparisons, right? So things that you want to be looking at, in my opinion, I'm going to really briefly try to touch on some. Does this system that you're looking at allow for multi-source data? As you're managing your patient population, it's going to be important to obtain and combine all these multiple sources, right? Which then is going to lead to patient match scenarios. Right? What's the identifier that you're matching out of your billing data that's going to link up with your clinical data? You want your vendor to be really comfortable with that piece of it. Also, custom reports. Sometimes there are questions that you're going to want answered in the data that are not just your 3 APP measures, right? Because we're managing so much more than just that quality piece. So is the vendor open to that? Can they create reports for you that answer specific questions? Do they have staff that they're willing to dedicate to spend the time running those analyses and that really have a sort of problem-solving, relationship-based mind with you? How quickly can that work be done? Is there additional cost for it? And obviously, they need to understand the specifications and not just give me my performance, but they've got to be able to calculate patient visits, denominators, numerators, exclusions, exceptions, performance rates, reporting rates, all of the things that you need as part of the submission, but you also need it for your own knowledge and for your own understanding to dig in and do that improvement. And then there's some security pieces to it as well.
Yeah.
I'm going to let Jeff speak to that.
Yeah, I was just thinking about this from I've managed engineering teams for a long time now, and I know how challenging it is to build all this stuff. What's even more challenging and easy to forget is once it's built, you got to take care of it. So whether you're building it yourself or buying something, you need to think about that total cost of ownership and knowing that we've talked about change. We've talked about change in data. We talked about change in measures. We talked about change in process. You're building a system. The system is going to just be subject to overall entropy, right? Everything outside the world is changing, and you've got to keep changing that system with it. So you got to take care of it. So make sure you understand what your total cost of ownership is and a commitment to ongoing maintenance. The other piece that's really huge right now is security. Healthcare data has become a really, really hot topic or a hot target for cyber criminals. You've heard all about ransomware, hospitals shutting down. I'm actually from Vermont. Our biggest hospital shut down for almost 6 weeks. It was devastating. It was a huge cost as far as putting it back together. So having security, and there's an industry around this. Make sure you know what your HIPAA regulations are and how you're meeting them. Having some security certification like SOC 2 or High Trust or both. Those are really shortcuts to knowing that your vendor or your engineering team has already done the hard work of being good data stewards and safe data stewards for this information that people are going to try and take.
Right. And you can see our last circle. Oh, sorry, I was going to say one more thing. So our last circle is on subject matter expertise, right? Which is another entire piece to when you are shopping for a vendor. This, again, is a big one that I love because I'm in charge of a consultant team. But the vendors that you're comparing, you want to make sure that they have experience across multiple CMS programs, in my opinion. Even in CMS, you guys know sometimes when you go to make a call to the help desk, that person understands this program. You need your regulatory expertise to be across all of the programs so that they can give you advice like, hey, what about primary care first? I see you have a large primary care population, right? You want to make sure that that vendor has a strong relationship with CMS. There are vendor-specific calls, and some vendors show up and just sit on them, and some vendors show up and advocate for their clients. And that's something that we see behind the scenes every day. So that's a great question to ask, is what kind of advocacy work do they do? Do they have a wide range of experience through multiple EMRs, obviously? And think about what EMRs have been sold into your key areas. There's a big difference between, I'm running an ACO in DC versus I'm running an ACO in Vermont, where you maybe have some rural, or in Nebraska, we even have frontier areas, very different EMRs in those areas, right? And does the vendor actually care about your year-over-year improvement? What you don't necessarily, in my opinion, want to fall into is somebody that's really just a submission grindhouse, because that is going to give you an idea about the level of customer support that you'll receive as you're trying to do your front of the half of the year work, where you're really trying to drive that improvement. You need somebody at your side to build a relationship with that is going to come along through that CAP process for you.
Yeah. And ACOs are moving to risk at lightning speed, so partner with someone who has had the failures, partner with someone who has experienced everything before, so you can make that jump quickly. So I'm going to conclude. We're talking about empowering providers, and so I got a quote from our CEO, and he talks a lot about giving data to the providers and letting them make the decisions that they need to make on a day-to-day basis. And you need to empower them through proper communication channels with data that makes sense, that's fair and understandable. And really, at the end of the day, it's about change management to value-based care. So with that, I'm going to say thank you, and if there are any questions, we're happy to take maybe one or two. Let's see, in the back.
Hi, so I have a question. So for the DCEs, we've been given the option to not just get the CCLFs, but to go in and pull data down on a daily or weekly basis, but you have to be very specific, like I want these discrete fields, and you pull them in. I wondered if you or any of your partners are doing that, so we can share which data you're choosing to pull in on a daily or weekly basis.
So what's nice is that, I'm forgetting the name of the time frame, but in the beginning, when they announced DCEs, they were given some sample files and compared it to the ACO data files, and they almost compare exactly. So we found that that data is pretty sufficient. I haven't looked to see exactly what additional data sources we might want or additional columns and fields, but I will say that what is being provided in the CCLFs is really robust, especially if you're comparing it to other payers.
I think one of the things I believe is available are those HCC scores. So having that risk information is going to be really important if you can get your hands on that.
And we can calculate that on the monthly level. So instead of just getting it on a quarterly basis and waiting, you can actually see the change a little bit more in real time. Any other questions? All right, we'll do the raffle drawing. Ryan, can you bring up the box? And make sure you guys give Ryan your business cards if you didn't already. All right. We'll have Allison do the drawing.
Last chance? We'll throw your business card in. Exactly right.
You gotta close your eyes.
I have to close my eyes.
We're going to put a mask over your eyes.
I'm not even in the box. Elite Patient Care, Jane McDonald. That's me.
Nice.
Wow.
Well, I'm hoping you guys had some takeaways. I don't love super high-level presentations, so I'm hoping you guys have something to take back with you. And if you need to come talk to us, first face-to-face, we're at booth A, right when you walk in on the left-hand side. So thank
Whether
you
you
so
need
much.
to or not, come talk to us.
Yeah, we're friendly.